Hi, we are going to discuss about bariatric surgery in this video. So basically, Edward Mason is father of bariatric surgery. So obesity is the second most common cause of preventable death. The first being smoking. Obesity is the second most common cause. So what is basically bariatric surgery? So bariatric surgery is a therapeutic intervention to understand and treat the cause and the sequel of morbid obesity. So obesity is a physiological dysfunction of human organism that deals with environmental, genetic, and endocrinology causes, and a major health problem with clearly established health implications. So before going into bariatric surgery, so the most important factor to deal with bariatric surgery is body mass index. So taking a body mass index into consideration, we plan certain things in bariatric surgery. So what is this body mass index? So it's calculated using a very simple formula: weight for height, like the weight in kilograms divided by square of the patient's height, like patient's height in meter square. So the degrees of obesity in the normal body mass index is 18.9 to 24.9 kilogram per meter square. And if the body mass index is between 25 to 29.9, it's overweight. So if the body mass index goes beyond this value, we call the as obesity. So obesity is classified into three classes: class 1, class 2, and class 3. And the BMI is between 30 to 34.9, it comes under class 1. And the BMI is 35 to 39.9, it comes under class 2. And when the BMI is more than 40, we call it as morbid obesity, like the patient is morbidly obese. So the other criteria to be morbidly obese is the patient's body weight is twice the ideal body weight, or like the patient is more than 100 pounds, or the BMI is more than or equal to 40, we call it as morbid obese patient. So there is a term called central obesity. So central obesity is like when the patient's waist circumference, in case of male patient, if the patient's waist circumference is more than 35 inch, and in case of female patients, if the waist circumference is more than 40, we call that as central obesity. There's one more term called super obesity. If the BMI is more than or equal to 60, it's super obesity. The etiology, coming to etiology, there will be some familial predisposition, poor lifestyle, sedentary lifestyle, and coming into genetic mutations, it's FTO gene mutation, fat mass and obesity related gene, melanocortin 4 receptor gene associated with obesity, increased fat mass and insulin resistance leading to diabetic mellitus. The main pathogenesis of obesity revolves around two main hormones, ghrelin and incretin. So when you take food, when the patient takes food, nutrition ingestion, when it reaches stomach or proximal intestine, there will be certain hormonal signals released, which in turn alter your body metabolism. One of the main hormones is ghrelin. So ghrelin is basically called as a orexogenic hormone. It's a 28 amino acid peptide, mainly secreted from the fundus of the stomach. It's an appetite stimulant. So ghrelin is an appetite stimulant, hunger hormone. So the exact opposite thing is the function of ghrelin is antagonized by insulin and cholecystokinin. They are anorexogenic hormones. So the second hormone is incretin. So there's incretin is glycagon-like peptide 1 analog. The main function of incretin is it stimulates insulin secretion from small intestine when the food reaches proximal small intestine. And so once insulin is secreted, so it helps in diabetic control. So the thing is, when duodenum is there, this duodenum will release certain agents like anti-incretin agents that will avert this diabetic control action of the incretin. So in most of the bypass surgeries, like in most of the bariatric surgery, bypass duodenum to tackle this effect of duodenum. So once duodenum is bypassed, so these anti-incretin agents, they are not secreted, and so the patient gets enough diabetic control along with the weight loss. And this hypothesis is called foregut hindgut hypothesis. So before going into surgeries, usually we try lifestyle modifications, psychotherapy, certain pharmacotherapies. So the drugs that are most commonly used in obesity is sibutramine and orlistat. The sibutramine it usually blocks the presynaptic receptor uptake of norepinephrine, serotonin, thereby potentiating their anorexogenic effect in the central nervous system. So the orlistat inhibits pancreatic lipase. So this pancreatic lipase secreted from pancreas is one of the major enzymes that will help in metabolization of fats. So when orlistat is given, it reduces fat absorption by at least approximately 30%. So this inhibits the digestion of dietary triglycerides, decreases absorption of cholesterol and lipid-soluble vitamins. So when bariatric surgery is planned, it's a multidisciplinary team, usually consists of a bariatric surgeon, physician, anesthetist, proper dietitian, specialist bariatric nurse, skilled data staff, and psychiatrist to motivate the patient. So coming into the indications, there are certain indications to proceed with bariatric surgery. When the body mass index is more than 40 kilogram per meter square. So if the body mass index is more than 50 kilogram per meter square, it's an absolute indication for surgery. But if the body mass index is more than or equal to 40, you can plan for surgery. And when the body mass index is, sorry, this is 35. The body mass index is 35 kilogram per meter square, along with certain comorbidities like diabetic mellitus for more than 10 years, associated with hypertension, coronary artery disease, obstructive sleep apnea, like this is called metabolic syndrome. So when these comorbids are associated with BMI of over 35 kilogram per meter square, it's also an indication for surgery. So when the BMI is more than 30 with the recent onset of diabetes mellitus, that is also an indication for bariatric surgery. So for Asian population, the cutoff value of this BMI is being decreased. It's 37.5 kilogram per meter square instead of 40. And it's 32.5 kilogram per meter square with the comorbids like diabetes mellitus, hypertension, obstructive sleep apnea in case of Asian population. So those patients who have failed to lose weight with the lifestyle modifications, pharmacotherapy, psychotherapy, they all get, those are all indications for bariatric surgery. So before going to surgery, the main things are like patients should be motivated, patients should stop smoking, chest physiotherapy should be initiated and encouraged, continued postoperatively. And there is a thing called fatty liver. If the patient has fatty liver, you should not proceed with surgery immediately. You should start the patient with liver shrinkage diet. So what is this liver shrinkage diet basically? This liver shrinkage diet is low carbohydrate and high protein diet. The patients are given low carbohydrate and high protein diet for at least 2 weeks. We should initiate this diet 2 weeks prior to surgery so that after 2 weeks we can plan for surgery. So what is BOMSS? It's British Obesity and Metabolic Surgery Society. So according to this BOMSS, there are certain biochemical parameters we have to do before operating the patient. So what are the recommendations? Like we have to do a fasting blood glucose, lipid profile, electrolytes, urea, creatinine, a complete blood count, serum calcium, vitamin D, thyroid function test, liver function test, and HbA1c. So in case of patients are with obstructive sleep apnea, you will have to do ABG measurements to evaluate the ventilation, the need for perioperative oxygen administration and post-operative ventilation. So post-operative oxygen is much needed in case of OSA patients to prevent anastomotic leak also. So there are certain contraindications where we should not do bariatric surgery, and the most important absolute contraindication of bariatric surgery is Prader-Willi syndrome. So in this Prader-Willi syndrome patients, they will have an like irresistible crave for eating. They can't diet or they can't control to take proper food or what. They will have a irresistible craving to take more food. So Prader-Willi syndrome is an absolute contraindication for proceeding with bariatric surgery. And other contraindications are like relative contraindications like age less than 18 years or above 60 years. If the patient is having poor family support, if the patient is psychologically unstable, who cannot make his own decisions, patients with drug abuse. So these are all patients where they who are relatively contraindicated for bariatric surgery. So obesity surgery mortality risk score. So what is it? We are operating a patient and we have to assess the mortality risk of these patients post operatively. So there is a score called obesity surgery mortality risk score. So it has 5 components, 5 criteria to be taken into account. Arterial hypertension, if the patient is more than 45 years old, if he is a male patient, and the BMI is less than or more than or equal to 50 kilogram per meter square. If there is any risk factors for deep vein thrombosis and pulmonary embolism. So each of these risk factors carry 1 point. So if the patient have any of these features, we will give 1 point for each factor, and we are classified into 3 categories like low risk patient, moderate risk patient, and high risk patient. So if the score is 0 to 1, the patients are categorized under low risk and the mortality rate is 0.3%. If the score is 2 to 3, it's classified under moderate risk and they have a chance of 1.7% mortality post-operatively. And if the score is 4 to 5, it's high risk for bariatric surgery and the mortality rate is 3.2%. So coming into surgeries, there are various surgeries being classified under 3 main categories. So the first being restrictive type of surgeries. The second is mostly they are restrictive but partly malabsorptive, and the third is completely or mostly malabsorptive surgeries. So you'll see what are the surgeries classified under these categories. So in case of restrictive surgery, the basic principle is you are restricting the amount of food taken by the patient so that it decreases the appetite and hunger, and the patient will attain early satiety. So the procedures are laparoscopic adjustable gastric banding and laparoscopic sleeve gastrectomy. So the second category, mostly they are restrictive, but certain amount of malabsorption also will be there. Those procedures are Roux-en-Y gastric bypass, mini gastric bypass with 1 anastomosis, because Roux-en-Y gastric bypass has 2 anastomosis. To overcome that, mini gastric bypass has only 1 anastomosis. So the third category is malabsorptive procedures, and this limits the digestion and absorption of the food. So we decrease the length of the intestine. So the time and the amount of like the length of the intestine exposed to the digestive food is very less. So these procedures are biliopancreatic diversion and biliopancreatic diversion with duodenal switch. There are 2 procedures. We'll see into it. This is the first procedure, laparoscopic adjustable gastric banding. It comes under restrictive type of surgeries. Stomach is made into a small pouch like this. This is the gastric band. So we have applied a gastric band and the stomach is made into a small pouch. So this is a stomach pouch, and it will create a sensation of fullness because it activates the stretch receptors. So the patient will have a sensation of fullness, and it also prolongs the sensation of fullness. So the patient will restrict his meal size and there will be decreased appetite and decreased calorie intake. So how it works? So this band basically it's laparoscopically applied in an oblique position, and it will have an access port externally. So this band is made in a way that it holds saline. So patient comes to the hospital every week, and through this access port, with the help of Huber needle, you inject saline 1 to 2 ml every week. So every week when the patient visits hospital, we will inject 1 to 2 ml of saline into the port, and it will reach the band and it will start compressing the stomach. So when we stop this procedure, so when are we going to stop this injecting saline every week? So when the patient attains expected weight loss, we are going to stop injecting saline and we are terminating the procedure. Uh, so basically, complications of this lap adjustable gastric banding is slippage of the band. So there are two techniques to do this lap adjustable gastric banding. Previously, a perigastric method was done. So with that method, the chances of slippage of this band was much more higher. So modification came. Now they have introduced a technique called pars flaccida technique. So pars flaccida technique is they approach the stomach through the lesser curvature and along the pars flaccida. So and they apply this band. So the slippage of band in this pars flaccida technique is very less. So when slippage happens, you see the band is applied obliquely here, and slippage happens. So it will slip and it will be like horizontal. So the orientation of this band will be horizontal and it will cause obstruction. Patient will have a sudden intolerance to food. There will be sudden onset of GRD. Patient will have obstructive symptoms, vomiting, everything will be there. And if you take X-ray, you will see signs of obstruction. So this is one of the complication with gastric banding. And the most common complication with gastric banding is port side leak, port side block, kinking of the port, like the tube, and infection. So all these complications can be managed locally with the help of local anesthesia. And the other complication is erosion of the band. So if there is erosion of the band, we have to remove and apply a new band. And most commonly, steroids are contraindicated in patients who have undergone lap adjustable gastric banding because it leads to erosion of band. Uh, so in India, actually, this procedure is not routinely done. Actually, it's banned in India. And one more thing is like you need a 100% cooperation from the patient, and that's very difficult task to achieve. So in India, lap adjustable gastric banding is not done. The second restrictive surgery is sleeve gastrectomy, and this is the surgery most commonly done nowadays. So lap sleeve gastrectomy is the most common surgery done nowadays. The stomach is like sleeve gastrectomy is what, like it involves resection of approximately around 2/3 or 80% of greater curvature of the stomach is left behind, and the remaining part of stomach is made into a smaller tubular structure. A sleeve is created with the help of bougie. So this is a laparoscopic sleeve gastrectomy. So this is the part that is left behind. This is the remote part of the stomach, and it is left behind. And this is the sleeve gastric part, and this sleeve is constructed with the help of bougie. So the bougie size is 32 to 36 French. So this 30 to 36 French bougie is most commonly used. And the ideal capacity of the new stomach sleeve stomach is 30 to 60 ml. 30 to 60 ml. This is 30 to 60 ml. So where do we start this dissection? So it's approximately 5 centimeter from the pylorus. So approximately 5 centimeter from the pylorus, you start stapling. So you start stapling from here, and you go on till the angle of this. So to reduce intraoperative bleed or postoperative bleed, after applying stapler here, they will do a procedure called buttressing to prevent or to minimize bleeding. So this is this part is left behind, and this is the newly constructed gastric pouch, which is about 30 to 60 ml. So the main mechanism behind this sleeve gastrectomy is mechanical restriction. So the patient will be taking very less amount of food and have more satiety. So there is also a major factor taken account here is hormonal modification. So previously I told ghrelin is one of the most important hormone, that is orexogenic hormone. So basically this ghrelin is secreted from the fundus, and by leaving out almost 80% of the stomach here, we are eliminating ghrelin hormone so that we are achieving more weight loss. So the complication of laparoscopic sleeve gastrectomy. So the Achilles heel of this surgery is leak at the angle of his. So you will have leak at this region. So this is the most common region where will you have leak. So the patient will have fever, tachycardia, upper abdominal pain, and they will have tenderness over the gastric region. So the first investigation and the investigation of choice is contrast enhanced CT, and you can do diagnostic laparoscopy also. The other complications are intra-abdominal bleed. I told they will use to do a procedure called buttressing to minimize the bleeding. And one more thing is GERD. So the patient will have GERD. So reflex. So laparoscopic sleeve gastrectomy is contraindicated in GERD patients. We don't do laparoscopic sleeve gastrectomy in GERD patients. So the next surgery is Roux-en-Y gastric bypass surgery. Laparoscopic Roux-en-Y gastric bypass surgery. So this surgery is mostly restrictive. Partially, it's of malabsorption also happens. So primarily causes weight loss by restricting the food intake. However, there is some amount of malabsorption that occurs with this operation. So basically, this surgery is you will divide the jejunum from the small intestine approximately 550 to 70 centimeter from the DJ junction. You will bring the dissected jejunum upwards, and this limb is called the roux limb. So the length of this roux limb is approximately 100 to 150 centimeter. So 150 centimeter. If you have this length of this roux limb like 150 centimeter, you will achieve more malabsorption and more weight loss. So if the patient is having severe obesity, you will use the 150 centimeter size of roux limb. So this roux limb is brought upwards and it's attached to the newly formed stomach pouch. The newly formed stomach pouches will be like approximately 50 to 20 ml, and gastrojejunal anastomosis is done. And this alimentary tract carries food. So the roux loop is completed by forming a jejunal-jejunostomy. Okay. So this is the newly formed gastric pouch, and it's separated from rest of the stomach. And this is the bypassed portion of the stomach, and this is left behind. And this is the jejunal end that was cut 50 to 70 centimeter from the DJ fracture. It's anastomosed to the gastric pouch, newly constructed gastric pouch through circular staplers. Okay, so this is the alimentary limb. The length of the limb is 100 to 150 centimeter, and this is the Y limb, and this is biliopancreatic limb. So this carry digestive juices, bile, and this is the common limb. So this is Roux-en-Y gastric bypass surgery. It has two anastomosis. One is gastrojejunal anastomosis, and the other one is jejunal anastomosis. So the complications of Roux-en-Y gastric binding is the most gastric bypass is most common deficiency is iron deficiency anemia, and the second one is vitamin B12 deficiency because of due to delayed action or very limited amount of action by intrinsic factor. Then calcium deficiency will be there, and the most common complication is certain hernias happen with this Roux-en-Y gastric bypass surgery. So when you divide this jejunum and you take this above, there are two methods to bring the jejunum to anastomose with this pouch. Those are anticolic method and retrocolic method. If you take this roux limb in front of the transverse colon and transverse mesocolon, it's called anticolic method. If you take this roux limb behind the transverse colon and mesocolon, it's called retrocolic method. So this Peterson hernia is what happens in anticolic method. So this happens behind the roux limb in front of the transverse colon, and the stamens hernia happens with retrocolic method. It happens in front of the roux limb behind the transverse colon. So this is diagnosed with diagnostic laparoscopy, and hernia can also occur at the jejunostomy site. And the other complication is anastomotic leak. So anastomotic leak is very less common when compared to laparoscopic sleeve gastrectomy. And the next thing is anastomotic stricture. The most common site for anastomotic stricture is this region, where gastrojejunal anastomosis has been done using circular staplers, and this region is more prone for anastomotic stricture. To overcome this anastomotic stricture, there are certain procedures to tackle these complications. The procedure is called ROSE, restorative obesity surgery endoluminally. So it's a kind of endoscopic procedure mainly to tackle these complications like anastomotic stricture arising in true and wide gastric finding. And there are other complications like marginal ulcers and GERD. So reflux can happen through this way. So gastric reflux can happen through this way. And the most dreadful complication of this GERD is if you have GERD, it will lead to Barrett esophagus that will end up in adenocarcinoma of esophagus. That's one of the complication of this true and wide gastric bypass surgery. So this is mini gastric bypass. So this is also mainly restrictive and partially malabsorptive. And we saw this is Roux-en-Y gastric bypass. These are two anastomosis here. One is gastrojejunal anastomosis and the other one is jejunojejunal anastomosis. So to overcome that, here instead of making a gastric pouch, sleeve gastrectomy is done. The stomach is made into a sleeve. The sleeve gastrectomy is done, and the jejunum is not divided. The jejunal loop is attached to the distal end of this newly constructed stomach. So this is the bypassed portion of the stomach. It's left behind, and only one anastomosis done, gastrojejunal anastomosis, with help of loop of jejunum. So the next final thing is malabsorptive surgeries. So what is malabsorptive surgery? We are giving very less time for the gastric, pancreatic, and biliary juices to interact with the food particles, so that the food particles are left undigested and they reach the colon and they are excreted by our feces. Okay, so biliopancreatic diversion is primarily malabsorptive. So here, instead of dissecting jejunum in Roux-en-Y gastric bypass, we are dividing ileum. We are using ileum as alimentary tract here. So we will see. So this is biliopancreatic diversion, and this is the divided ileum. So initially, a distal gastrectomy is done. Distal gastrectomy is done, and the stomach is taken out. So the stomach is made into a new pouch, and the capacity of the stomach is approximately 200 ml. So this is the divided ileal part. So distal ileum is divided in a way that this is alimentary. This is the alimentary tract which carries food, and the length of this tract is 200 centimeter. So this is 200 centimeter, and this is the biliopancreatico-duodenal limb that carries digestive juices, and it is attached here. This is the area where we divided the ileum. So here we do ilio-ileal anastomosis, and here this is ilio-ileal anastomosis, and here we do gastro-ileal anastomosis. So this is the common channel. So this is biliopancreatic limb. This is alimentary tube. So this is the common channel, and the length of this common channel will be 50 centimeter. This is 200 centimeter, and this is 50 centimeter. A very less length is being provided for the food coming through this tube and the digestive juices coming through this channel to interact. So most of the ingested food particles are moving into the colon without digestion and excreted via feces. So this is the main mechanism behind malabsorption that happens in biliopancreatic diversion. So the major, one of the most important complication that was seen in biliopancreatic diversion is marginal ulcers. So basically, so when normally in a person, when the food reaches stomach and then to small intestine, the duodenum will release will give feedback inhibition to the stomach, so that the stomach will secrete less amount of acid secretion. There will be feedback inhibition for decreasing the amount of acid being secreted. So when you eliminate the duodenum in biliopancreatic surgery, so you have done distal gastrectomy and there is no connection between stomach and duodenum. So now there is loss of feedback inhibition here, and the main complication here is marginal ulcers. So to overcome that, to overcome this complication of marginal ulcers, they modified this procedure called biliopancreatic diversion with duodenal switch. So what they did here is, instead of doing distal gastrectomy, they constructed with the help of bougie, they constructed a sleeve gastrectomy pouch. So this is the sleeve gastrectomy pouch, and they included D1 in this sleeve gastrectomy pouch. This is the part where they divided the duodenum, and this is D2, D3, and D4. But D1 is included with this sleeve gastrectomy pouch. So now that the feedback inhibition will be sent to stomach, and there will be very less amount of acid secretion, and this marginal ulcers are not happening here. So the sleeve gastrectomy, and again the same procedure. We are dividing the ileum. Ileum is brought upwards, and it's now anastomosed to duodenum. So instead of gastroileal anastomosis, duodeno-ileal anastomosis is being done. And this is the other limb which carry digestive juices, and this is ileo-ileal anastomosis. And here the length of this alimentary tract is 150 centimeter. So there it was almost 200 centimeter. Here the length of the alimentary tract which carries food from duodenum through duodenum is 150 centimeter, and the length of the common channel here is 100 centimeter. There it was 50 centimeter, and here the length of this common channel is 100 centimeter. Rest are all same. So after surgery, according to British Obesity and Metabolic Surgery Society, we did all the baseline biochemical parameters. So you have to repeat all the biochemical parameters post-operatively, and you have also to repeat zinc and copper annually. If warranted, if the patient have night blindness, coagulopathies, metabolic bone disease, cardiac failure, chronic diarrhea, sudden onset chronic fatigue, sudden onset or chronic fatigue. So you have to check for other micronutrients and vitamins like vitamin E, A, E, K, selenium if needed. So coming to the mortality rates. So mortality rates in lab adjustable gas, we are not doing this here in India. The mortality rate is 0.1%. And the most common procedure done nowadays in our country is laparoscopic sleeve gastrectomy, and the mortality rate is 0.1%. In a laparoscopic Roux-en-Y gastric bypass, the mortality rate is 0.5%, and in biliopancreatic diversion, the mortality rate is 1%. So what is the cause for this mortality? So if the mortality happens less than 30 days, it's mainly due to anastomotic leak. If it happens more after 30 days, the most common cause is DVT and pulmonary embolism. And the overall most common cause for mortality in bariatric surgery is DVT and pulmonary embolism. So there are certain endoscopic procedures we do in case of bariatric surgeries, like intragastric balloon, Orbera, reshaped balloon, pose. So pose is primary obesity surgery endoluminally. So they will endoscopically they will insert the scope, and they will do multiple sutures. The instrument will do multiple sutures so that the capacity of the stomach is very much reduced. And Rose is already we saw restorative obesity surgery endoscopically to tackle the complication of anastomotic stricture in Roux-en-Y gastric bypass. Toga is transoral gastroplasty. So endoluminally they'll fire staplers so that to achieve weight loss.